I think we're going to get started again. Uh, and I'm very excited to introduce you to Dr. Erin Andrews, someone who I've had the pleasure to get to know through the American Psychological Association. Go ahead, thank you.
All right, thank you so much for welcoming me here. I'm going to go ahead and share my screen now. All right, hopefully everybody can see that. Okay, well, again, I want to thank everybody for inviting me to come and present to you today. I'm going to be talking to you about a lot of different things. I'm going to try to cover a lot of different things. And so I'm going to go quickly, but I'm also going to hopefully provide you with some resources so that if you want more information about the things that I'm talking about today, you will be able to get those. Okay. So this talk is entitled Disability Justice During the COVID-19 Pandemic, and this is about what you as psychologists and neuropsychologists need to know. So I've got to make my appropriate disclosures that this is not associated with my employment at the VA. I'm not speaking on behalf of VA or the medical school where I have a faculty appointment at the University of Texas here in Austin. So we've got an ambitious set of learning objectives here. And what I'm going to be doing primarily today is setting the foundation and talking to you a little bit about disability as diversity and helping you to understand why that's important and why attitudes and ableism play a role in the experiences of people with disabilities. And then I'm going to shift over to talking about health disparities. And after that, I will get into what COVID has done to the disability community and 3 main ways you can help. Okay, so we hear about disability as diversity, but it often receives little more than lip service. So whenever you see these definitions of diversity, inclusion, we see disability on the list, but when you really look at diversity education, whether that be, through graduate school, through continuing education, disability is often left out. And one of the reasons for that is because it's much easier in society because of the stereotypes and biases we have to think of disability through the medical model as kind of an individual problem rather than a cultural experience. And that's kind of what I'm going to challenge you a little bit today to do. So a lot of times when we do hear about disability, we hear about the ADA, what are the laws? What are the bare minimum requirements? And that's important, but that's only one small aspect of the disability experience. So I don't have the time or the ability in this presentation to give you a full overview of all the disability models, but I briefly mentioned the medical model, and that is still pretty predominant in American society, that disability is a medical problem that needs a cure. And I've highlighted the bottom model, which is the diversity model. And that's the model that I'm going to be mostly speaking from. And that is that disability is seen under the diversity model as an individual difference that's within the spectrum of diversity and of normality. And that it's also a cultural experience rather than solely a medical experience. And I neglected to mention at the beginning that I have a disability myself. So I have a physical disability. I am a triple amputee. I know you can't see that on Zoom. I'm just getting used to having to disclose my disability, which primarily is never something I have to do because I use a power wheelchair and I have 3 missing limbs. So it's always interesting to disclose that. So this is a graphic representation of one of these models, the social model, but I think it represents a lot of the pieces of the diversity model very well, because the social model was kind of the foundation for the diversity model. And so this has, I love graphics. So you're going to see tons of graphics. So you see the classic or stereotypical person in a wheelchair to represent the person with an impairment. And then you've got the environment over here on the right, right? So all of the physical, social, economic, and political barriers. And then in the middle here, you have the interpersonal and social elements, right? You've got exclusion, oppression, stereotyping. And so this kind of does a lot to show that the barriers faced by disabled persons are much more so in the environment than in the actual within the individual. So this is another graphic that kind of shows the things that predict someone's experience as a person with a disability. So disability is part of that, right? So it's up here in the upper left quadrant, right? Disability variables, what type of disability you have, the severity of it, you know, how much assistance you need for activities of daily living, sure. But that's only 1/4 of this pie, right? So there's also your socio-demographic background, right? In terms of your other, you know, identities, who you are, where you come from. You've got environmental barriers, where you live, your income, whether or not you're able to work, whether or not you have a job. And then of course, personality, right? As psychologists, we know that personality is really important because it plays into how we're going to respond to situations. So that is all to say that the disability itself is only a small portion of a person's overall experience. And of course, these are not all four equal, you know, they each account for 1/4, but they certainly all do account for some of the totality of the person's experience. So I thought we would do a quick pop quiz if you want to in the chat box. Anybody want to guess where did eugenic sterilization occur first? And I mean sterilization of disabled people to stop them from reproducing. Did it happen first in the US or in Nazi Germany? Any guesses? You'll have to tell me if there's any guesses, Sarah.
Not so, I don't see. Oh, yeah, we get quite a few US.
US. All right. So you guys are ahead of the curve. A lot of people think, oh my gosh, that's something terrible that the Nazis did. But the reality is the Nazis actually learned and modeled their T4 program, which was the involuntary sterilization of disabled people, from what the US was already doing. All right. Another question. When do folks think involuntary sterilization of disabled people generally ended in the US? Any guesses? Just give me a decade.
Nothing yet, but I think it takes people time to throw it in there. You've got a 1960. You've got
Okay, good guess.
you've got a has it.
Has it? Well, yeah, I'm going to speak to that. So 1960s is close, but actually there are cases, documented cases, and that's important, right? Because, you know, documented involuntary sterilization occurring into the 1970s, which I don't know about to you all, but that still feels very recent. But it's a good question. Has it even ended? Well, first of all, no. Certainly not for a number of vulnerable and marginalized groups. We just recently heard about undocumented immigrants who are detained in camps, being sterilized coercively, if not straight involuntarily. And I think a lot of that coercive type of thing absolutely is going on every day here in the United States for people with disabilities, because other folks who have power over other individuals' lives can convince them, this is what you should do, or this is what is the right thing to do. So we have a long and kind of nasty history with how we've treated disabled people in our country. But I want to talk to you a little bit about what attitudes towards disabled people can look like. And this one I call the continuum of social proximity. And what this is about is it's about how attitudes are related to our relationship to someone with a disability or to people with disabilities. So there's a lot of assumptions that people make, or even, as psychology has made historically. For example, that, people who are family members, if you have a family member with a disability, then you would have more positive attitudes towards people with disabilities. And that's actually an example of something that doesn't bear out in the literature. So you can see that being a peer or a coworker, being a family member, or having minimal contact with disabled people, there's no effect on attitudes. It's kind of just neutral, some positive, some negative. There's no real findings there. Now, in terms of positive attitudes towards people with disabilities, we tend to see that when the relationship has a power differential where the disabled person is in a power up position. So when I'm your supervisor or your boss, when I am your instructor, your professor, that is associated with more positive attitudes toward disabled people. And on the flip end, on the negative side, when the research asks people about how would you feel about dating someone with a disability, or would you consider a disabled person as an intimate or romantic partner, that elicits negative attitudes, as does what we would expect, negative contact. If you've had some negative experiences with the disability community, that's another thing that's associated with negative attitudes. So when we talk about negative attitudes, I want to talk about ableism. So ableism is the term that is used to describe prejudicial attitudes and discriminatory behavior. And, some people kind of eschew this as just another politically correct term, and I assure you it's not. Ableism, like sexism and racism, is very real. It's been studied and it is experienced, I will confirm, daily in the lives of disabled people. So you have, these myths and stereotypes, and unfortunately they've been really reinforced in the media. So we see a lot of really pitiful portrayals of people with disabilities in the media, or these really kind of heroic portrayals. And I'll talk more about the difference there in a minute. But basically, just like with other groups who are marginalized, there's a cumulative effect of these negative attitudes, and many of you should be familiar with the term microaggressions. There is a cumulative effect on people with disabilities. Now, from the outsider's perspective, ableism is often subtle and it's often unconscious. It's not necessarily purposeful. I'm trying to be hateful towards disabled people. Oftentimes, non-disabled people aren't even aware that their prejudices are at work. So when we think about ableism, it's important to look at explicit versus implicit. And I'm betting and hoping that many of you are familiar with the implicit association test that you can take online through Harvard. You can take it based on many different identities. So when we've looked at the IATs as a whole, the attitudes that people show toward disability are among the most negative of all of the marginalized identities included in the IAT. Now, family members, interestingly, have lower explicit bias, but the same level of implicit bias as non-family members. And what that suggests is family members kind of know that they shouldn't, right, feel that way or experience that. But when we're looking at the implicit, it's still there. disabled people themselves have less of both explicit and implicit negative attitudes, but they still have a moderate preference for non-disabled people. And that speaks to the internalized ableism, which makes perfect sense because we've all been raised in society, the same society that tells us disability is bad. The other couple that are interesting from the IAT is that women tend to feel more favorably toward people with disabilities generally than men. And also, as education increases, the explicit bias does decrease, but implicit bias increases. So that's a real interesting finding. I think that it certainly suggests that as you become more educated, you realize it's socially inappropriate or wrong to express explicitly those kind of attitudes. But then the implicit bias increase is curious, and I guess my hypothesis about that is that as people progress to higher levels of education, they may find that they have a higher value on certain things that could be affected by disability. So what I'm thinking about is cognitive functioning. If you're somebody that's really important to you, maybe one of the most important things, maybe that elicits some fear or some bias about the disability experience. But that's just the guess. That's one of the areas we just don't know enough in the research to say for sure. So this slide depicts the catastrophize, sensationalize continuum. And this is what the attitudes look like across the spectrum. So what I was speaking about earlier is some of those explicit attitudes that are negative. So people with disabilities may be viewed as dependent, vulnerable, pitiful, incompetent. The spread effect means that the person's disability is kind of generalized to their whole self. So maybe somebody sees that I have a physical disability and then they also assume that I have a cognitive disability. So there's that, and those are certainly problematic. But then you have way over here on the other end of the spectrum, these overly positive attitudes. And you might be thinking, well, how is that a problem? And I'll tell you why it's a problem, because these are extreme types of attitudes. These are, people with disabilities are so inspirational. They're so courageous. I mean, sometimes I get this, I'll be going to the grocery store. Oh, pre-COVID, I'd be going to the grocery store. And some random person would come up to me and be like, "You are so courageous to be here at Costco today." And I'm like thinking, what? That makes no sense, right? So this kind of heroic, superhuman, disabled person. And so the reason why both of these are problematic is just because they're so extreme. So when we endorse the extremes, then we diminish the middle, which is where the human element is, right? So if we put people into these boxes, we dehumanize them and we don't allow them to be both flawed and have strengths. So I used to title this slide, "Is there a disability culture?" But I decided, starting with you all, that I'm going to title it, "There is a disability culture," because even though you may not know about it, there is a disability culture. And it's unique because the disability culture is not analogous to, other types of culture. There's differences. And probably the major difference is that anybody in our society could join the group, become disabled at any given time. And that's just simply not the case for other types of identities. I'm not going to wake up tomorrow and be a man, right? That's just not how it works. So what we are talking about when we talk about disability culture is taking back our identity. So it's been historically viewed so negatively. And that's why disability culture can seem really counterintuitive. Like, why would you celebrate there's something wrong with you? That just doesn't make sense a lot of times to outsiders. But it is continuing to develop. And one of the things that's helped it develop is disability studies as a discipline, which is a relatively young academic discipline. So it's not new, but it's just recently been recognized, I think, and really given much attention. So for disability culture, it promotes connection and camaraderie among people with disabilities. So it's us coming together. And it's interesting because we are indeed the largest minority group in the US in terms of numbers, but we haven't historically had as much opportunity to come together. And so the motivation of disability culture is to address our own civil, social, political, and economic needs, right? Rather than, letting non-disabled people, take care of us. It's us kind of taking control of our own destinies. So this is up in the upper right-hand corner, a symbol of disability culture. So you notice that it's a wheelchair, but it's made into a heart, and it's an expression of disability pride. And so identifying with disability culture allows somebody to feel like they belong and have shared beliefs and heritage. And you might be asking, what are you talking about, heritage, right? Like, I'm not necessarily related to all these people who have disabilities. But what there is there's a heritage in terms of disability rights and activism. So if anybody has not gotten a chance yet to get on Netflix and watch the documentary Crip Camp, I want you to watch it. That's your homework assignment from this presentation. That's our heritage. You see the people who have gone before us, who have fought for our rights. That is our heritage, and those are the people. So it's an expression of pride. It's not just, oh, we're oppressed or we're discriminated against, and so we're going to band together. It's beyond that. It's about pride. So there's a lot more. I could talk about disability culture for a long time, but there's a lot more to it. But one of the things that's most important for what I'm presenting on today is the difference between independence and autonomy. And so in American culture, we really value independence, meaning being able to do things yourself, not being dependent or reliant on others. And just the freedom of independence. That's a very important in American culture. And you will often hear attitudes towards disability that reflect that discomfort when people think about not having independence. So I often hear people say, oh, I would hate if I had a horrible disability where I was not able to walk or hardly move. If I had to have, someone help me go to the bathroom, I mean, I would rather be dead, right? That's where that attitude is coming from. The loss of independence is seen as that crucial in our culture. But in disability culture, what we value is autonomy, not independence. And that is, how much control do I have over my quality of life? Am I able to make decisions about how my life is going to go? And am I going to get choices about my life? So I'll give you an example of exactly the opposite. So you've got people who are terrified to have someone help them go to the bathroom, but I could name, right off the top of my head, 5 very high functioning, professional people, psychologists, attorneys, physicians, that they have a personal care attendant that comes into their house every morning and helps them go to the bathroom. And that's every day. And that is not seen as demeaning. That is not seen as a loss of dignity, because those folks are in control. They are autonomous. Things are done the way that they want them done. And that is fine in disability culture. We don't care so much about the independence. It's really all about the autonomy. Okay. So let's move on to health disparities. So one of the things that I really want you to come away today understanding is that we have some serious health disparities going on in terms of people with disabilities, both in our country, but also worldwide. So what gets tricky is sometimes people use health and disability synonymously, and that can be a problem. So while sometimes people have a chronic health condition that causes them to have disability, or they may identify as a person with disability, that's not always mean that they're in, just because someone has a disability doesn't mean they're in poor health, right? So you can have a disability and be unhealthy. You can have a disability and be healthy. It's more complex. But what happens that we see is when we conflate health with disability, we kind of give up on the disability community, and we don't work so hard to make sure that they're getting health promotion and disease prevention efforts that they really need. And this has had some pretty awful effects. So just a few statistics here. Grown-ups, I have 2 kids at home. I think that's where bleeding over. Adults, I can say adults, with disabilities are 4 times more likely to report that they have fair or poor health compared to non-disabled people. And it's a drastic difference. Disability in adults is associated with the behavioral risk factors that we know are poor for health, and especially cardiovascular health, which is one of the leading killers, right? So smoking, decreased physical activity, and obesity. People with disabilities have the same needs for preventative health care, immunizations, cancer screenings, but they're not getting them at the same rates as non-disabled people are. Disabled people are also on a narrower margin of health. So if you're living in poverty or close to poverty, or if you're socially excluded, or you're vulnerable to secondary conditions, like for example, pressure sores or UTIs, it just takes one hospitalization that can lead to death because you're living on such a narrow margin of health. And the other thing is those attitudes that I've been talking about. Those are not just, laypersons. These are happening in our hospitals, in health and rehabilitation, in our clinics, across healthcare, they are happening. So when we talk about health disparities, I'm sure you know what I'm talking about, but just in case you want a refresher, I'm talking about differences in health outcomes at the population level. And these are things that are considered to be avoidable, and it's linked to social, economic, and environmental conditions. And so we know that across a huge range of health indicators and the social determinants of health, disabled people fare far worse. So this is an image that is a graphic of the health disparity. So you've got health status here, and this first one is the general population. Then you have people with disabilities, and then this is the difference between them, which represents the disparity. And then these things on the right are what we believe accounts for them. Now there's some things like genetics or social circumstances, environmental conditions that, they vary in how much you can influence them. But with health promotion and with medical care access, that is one area where we know we can make a much bigger difference. So these are some graphics from the World Health Organization. So remember, this is kind of the global perspective. But again, I think it's very helpful to know that we have over 1 billion people, 1 in 7 globally, and in the US, we believe it's probably up to 1 in 4 now, between 1 in 4 and 1 in 5. But we're still 2 times more likely to find healthcare providers' skills and facilities inadequate, 3 times more likely to be denied healthcare, and 4 times more likely to be treated badly in the healthcare system. So half the people with disabilities cannot even afford healthcare. And there's a lot of systemic problems that I don't have time, unfortunately, to go in today why that is the case. They are 50% more likely to suffer a catastrophic health expenditure. And part of that is people with disabilities are more vulnerable to injury, both accidental injury and violent injury. So disabled people are disproportionately affected by violence, including criminal violence. So these out-of-pocket expenses, again, you've got folks living on this narrow margin, can completely push someone's family into poverty if they're not there already. And we're just not doing a good enough job of meeting the needs of our disabled population. So here at the bottom, it just talks about how there's not enough wheelchairs, there's not enough people who need glasses, have glasses, not enough people who could benefit from a hearing aid are getting them. And so it's really important that we do everything that we can do to reduce these disparities. And I'm going to talk to you more specifically here in a bit about what I think you can do. We need to remove barriers to health facilities, information, and equipment. We need to make healthcare more affordable. We need to train healthcare workers, including psychologists, in disability issues and disability rights. And then, of course, investing in specific services, particularly rehab services that so many people simply aren't getting. So I've kind of touched on this, but I just want you to be aware of what some of the barriers are. You know, there's these tons of physical barriers, you know, just being able to go to the doctor and have an exam when the exam tables don't go up and down. The ADA, while a wonderful piece of legislation, has a lot of loopholes and a lot of gray area, and it's not very enforceable. And so it's violated all the time and nobody does anything about it. People with disabilities are excluded from public health and biomedical research studies. And I'm going to talk more about this in a few minutes, or what we can do differently. But, you know, all of you know what it's like to go through the IRB, whether you do research now or whether you know, when you did your dissertation, you know, years ago. You know, the IRB is to protect human subjects research, right? And so there can be this kind of paternalistic oversight that we see, and it has unintended consequences. So, you know, sometimes you see, okay, you know, vulnerable populations, what is your rationale for including a vulnerable population in your research? What are you going to do to protect them? Well, if I'm the researcher and I already have to get through this bear of an IRB, I might say something like, I'm not even going to bother with that. I don't want to have to justify. Let's just get non-disabled people, non-elderly people, right? And we're seeing this with COVID, right? Because we're not seeing as many people involved in vaccine trials who are elderly, who are disabled, who have comorbid health conditions. But what's ironic is those are the people who need the vaccine the most, and we need to understand the harms and the effects that it may have. So that's a huge problem. I've already talked about the physical and environmental issues, the attitudinal prejudice and discrimination. We are not immune from that, not as psychologists, and certainly not medical providers. Medical providers often they're trained in the medical model, and so they oftentimes have some significant biases toward people with disabilities. And it's not, again, this hostile, I hate people with disabilities. It's more like, oh my gosh, their life must be so awful, we should try to cure them. So I want to shift gears now and talk more directly about COVID-19. And then I'm going to get into what I think some of the things are that you're going to be able to do. So this guy here is a gentleman named Michael Hickson, and he lived here where I live in Austin, Texas, and he died in June. He was 46 years old, and he died of COVID. And this case made a lot of headlines. Not at first it didn't, but eventually it did, because of the information that was obtained through a recording that his wife had made of an interaction with the ICU doctor about deciding not to continue with life-saving care, not to even begin life-saving care for Mr. Hickson. So the background on Mr. Hickson is he's 46 years old. He's got 5 lovely kids. You can see them there in the picture with him. And he was in a car accident, and he sustained both brain and spinal cord injuries. So he had pre-existing brain and spinal cord injuries. He's been living in an assisted living facility prior to June. His wife was trying to work with the state and county and all this stuff to get the resources to have him live back in the home with her and the kids, but that hadn't happened yet. And he got COVID while he was in the assisted living facility. So I'm going to play a little bit of this to you, and it's just about 2 minutes. We're going to listen to it. I'm going to turn it up as loud as possible, but there is captioning on the screen, so hopefully if you're having trouble hearing it, you will be able to catch that. So bear with me as I fast forward to where I want it to start.
With the decision is, do we want to be extremely aggressive with his care, or do we feel like this will be futile? And the big question of futility is one that we always question. And the issue is, will this help him improve his quality of life? Will this help him improve anything? And will it ultimately change the outcome? And the thought is, the answer is no to all of those.
But what would make you say no to all of those?
Because as of right now, his quality of life, he doesn't have much of one.
What do you mean?
So these are
because he's paralyzed with a brain injury, he doesn't have quality of life.
correct.
Who gets to make that decision whether somebody's quality of life, if they have a disability
Well,
or
it's definitely not
handicap,
me.
their quality of life is not good?
So it's not me. I don't make that decision. However, it's will it affect his quality? Will it improve his quality of life? No, the answer is no.
But why wouldn't it? Being able to live isn't improving the quality of life?
There's no improvement with being intubated with a bunch of lines and tubes in your body and being on a ventilator for more than 2 weeks. Each of our people here have COVID and they're in respiratory failure. They've been here for more than 2 weeks.
So they basically are people who are just holding God.
If I were to be frank, yes.
So if somebody doesn't die, are you going to think that that was just
So
chance?
I can count with one hand. There's 3 patients that have made it through.
But you can count 3.
Correct.
Okay.
Correct. Exactly. And I get your point. Like there are 3. However, he doesn't fit those 3. Those 3 are young people that don't have medical problems. This guy is young, but he has a number of medical problems.
Okay. So I'm going to go ahead and stop it there. There is, I'm sorry. There is more, there is more, but I don't want to spend any more time on it. If you're interested, you know, please do look at it. NPR did a really nice piece on it, and this I have up here in case the video didn't work. But what you're hearing there is that they're making quality of life judgments about him, and then they're linking their treatment decisions about his COVID to his pre-existing disability. And so this is really important for a number of reasons. But the thing is that with COVID here in Austin, Texas, again, where this took place, this was in early June. We were not at a point of rationing care in early June. There was not a shortage of ventilators. There was not a shortage of ICU beds. So the concern in the disability community has been, oh my gosh, rationing. When there's not enough for everyone, we're going to be the first ones that they're going to let die. But this wasn't even, it wasn't even because there was a shortage. It was just a straight up quality of life, you know. He has no quality of life. Other people are walking and talking. And so, you know, it's just not worth it, you know? So it's pretty heartbreaking and caused a lot of uproar, as you can imagine. So I wanted to share Mr. Hickson's case with you because I think that anytime we talk about these things, it's important to make it real. These are real people that are being affected, real lives. And now I'm going to talk about the 3 different things that I think that you can do as psychologists to address the concerns and the issues that I've laid out for you guys to hear today. So I can't give you a whole lecture on cultural competence and disability, but what I'm going to do is talk to you a little bit about therapy and a little bit about assessment. And it's important to understand that as psychologists, most of us were never trained sufficiently in disability issues. Many of us don't have a very good understanding of the disability rights movement or about, you know, attitudes and health disparities that affect disabled people. So don't beat up on yourself if you don't know much, because most psychologists don't. And oftentimes what happens is psychologists can, just like anybody, feel discomfort working with disabled people and be unsure how to respond, right? So that can unfortunately lead to making erroneous assumptions or causing damage in the therapeutic relationship. So, you know, as a patient comes into your practice and you notice that they're in a wheelchair and you're getting all like visibly uncomfortable and you don't know what to do. Should you open the door? Should you move the chair? You know, that's all, the patient is absorbing all of that and experiencing all of that. So, you know, I would argue that gaining cultural competency and skills in this area is really important, especially if you're going to work with people with disabilities. And you probably do, even if you're not thinking of it that way, because we know, again, between 1 in 4 and 1 in 5 Americans is disabled. So it's often one of the biggest mistakes I see psychologists make is to assume that the reason why the person is there is because they're distressed about their disability. And that's an important assumption not to make, because people with disabilities seek psychological care for a whole range of services, just like non-disabled people. It might be relationship issues, it might be a depression, it might be a psychotic disorder, right? So it doesn't necessarily have to do, with the disability, but then at the same time, their disability may interact with those elements of their life. So it's important to, first of all, self-reflect on your own thoughts and emotions related to disability. And it's totally normal to feel anxious, vulnerable, and even sometimes repulsed when working with disabled clients. I had a trainee once that struggled a lot with working with patients with severe burn injuries. And, so we have to do that work. And we know we have to do it with other groups, other identities. We know it's important, and it's also important with disability. So in my book, which I will shamelessly peddle at the end, or at least put in an advert for, you can learn a lot more about things you can do in psychotherapy. But some general considerations, some really practical take-home ideas are being as flexible as you can in terms of session length, frequency, and time. Now we've all been kind of put in a position where most of us are doing some amount of virtual care. Patients with disabilities have been begging for that for a long, long time. That's something that can make treatment accessible if someone has difficulty with transportation or they're not able to drive. There's lots and lots of different things that you can do to change up or adapt your psychotherapy to best fit this person and their particular disability considerations. Another one I think is really important is encouraging peer support. One of the things that people with disabilities will often richly gain from is talking to other people who have been through what they've been through, whether it be, a spinal cord injury or any other kind of disability. One of the programs that I'm involved in that Dr. Raskin noted at the beginning is that we have the Disabled Parenting Project, and that helps connect disabled parents to other parents so that they can talk about what it's like and give them advice when, the OBGYN says you have to have a C-section, or when you get a divorce and your non-disabled, spouse is trying to take away your custody of your kids and using your disability against you. So some strategies specific to cognitive disabilities I've listed separately here, just because, it was an easier way to group them together for the slides. But things like audio recording sessions, modifying, if you're doing certain interventions, you can modify them into smaller chunks. Being aware of your language is hard as we try. Psychologists are notorious for jargon. So, working on making our language more accessible. And there's lots and lots of different things that you can do practical things that you can do to accommodate the needs of your patients in psychotherapy. Now I need to switch over to talking about what you can do for assessment. And this is complicated. It's all complicated, but I'm going to try to just hit the highlights. So we know that when you're doing assessment with disabled people, there's a bunch of problems that can come up. So sometimes the disabilities themselves can affect aspects of assessment performance, both on psychological and on neurocognitive tests. And then you also often have disabled patients who also have secondary disabilities or other comorbid conditions. So you want to make sure that you're considering the disability, and as you're thinking about your test selection and how you're going to conduct the assessment, you want to really make sure that you're measuring the appropriate construct, right? So again, if we're trying to, for example, measure, processing speed, and you're going to give, trails A and B to someone with a spinal cord injury that has difficulty using their hands, you're probably going to do a better job of measuring their spinal cord injury than you are their cognitive processing speed. So we know that some tests are just going to be confounded, like that example that I just gave. Another common one is certain self-report inventories, like the BDI, can sometimes artificially inflate depression because there's so many physical symptoms on there that could be accounted for by the disability. So there's many different examples of these. So you want to be very careful so that you're not, kind of drawing misleading conclusions and ultimately making unsuitable treatment recommendations. So there's a lot of work that goes into it, right? We have to look at the validity information and, whether or not this instrument has been used with people with particular disabilities, just like we would for other diverse groups. But the problem, yet again, like I said with research, is so often people with disabilities are left out of these research studies. We're left out of these normative samples. And so oftentimes it is very difficult to actually find measures that are well normed on the disability community. So oftentimes you have to supplement those measures by, kind of qualitative and functional assessments in order to get, I think, a better and truer picture of that person's functioning. So what I'm asking you to do is be creative and be flexible when you're thinking about assessment of people with disabilities. So thinking about, some ways that we can alter protocols, that's something you have to really think about. You have to really weigh the pros and cons, and you have to disclose that obviously when you're writing up your assessment. But it's a misconception I have found that altering test procedures compromises the validity of the administration. That's kind of like the knee-jerk reaction I get all the time. And I'm not saying that alteration is always warranted, because it's not. But there's a difference. There's two different kinds of alterations you can make to the testing environment, procedures, format, or content. Accommodations are changes that we use to improve access to the test that do not affect the particular construct being measured. So that is something that makes it so that the person has a fair chance to complete the measure, but it's not changing the construct you're measuring. Modifications do affect the identified construct. And so a modification is actually what poses a threat to validity, whereas an accommodation does not. And I know that's complicated, but I think when you're thinking about whether you want to make an alteration, that's the question I'd want to ask myself. Is what I'm saying I might do here going to affect the actual construct that I'm trying to measure? So COVID has just challenged us so much in terms of assessment. I know for the neuropsychologists especially. And so we really have to be creative and determined, because these assessments are so important to so many of our clients. Sometimes their lives are depending on it. And so, I think it's easy to just kind of say, oh, we can't do it. But I would challenge you to say, what can we do? Because you have wonderful training and expertise and knowledge as neuropsychologists. And, if they don't get, some assessment or some, good quality service, they may go without. And again, like the case of Mr. Hickson, we see that it can be a life and death issue. So this graphic explains the difference between equality, equity, and liberation. And what does this have to do with assessment? What it has to do with assessment is that I want us to eventually have liberation, where we have universal access to so many more of our tests and measures, and we can have them normed on a much greater variety of people and be able to give them without, having to do so much work of finding, what's going to work for this one person. Because what we're used to is equality on the left side. See all the three people, they each get the same thing. They're each getting one crate to stand on. That's equality, it's equal. Now in the middle picture, that's what we're doing with accommodations that I just talked about. It's equity. We're changing things up, we're tailoring it based on the person's needs, and so that they all are able to see at the same height. Right? This person on the left didn't need any accommodations. The person in the middle needed one crate, and the person on the right needed two. But liberation is what universal design would look like. And that's where, instead of focusing what we're doing on the person, we change the environment, the structure itself, and we create a barrier-free environment for all individuals. So now I'm going to talk about research, and then I'm going to talk about advocacy, and I'll make time for you all to ask them questions. So I've already said one of the biggest problems is that people with disabilities are not involved in research as participants, and that's a huge problem. So one thing I would like you to do is try to the extent that you're able, include disabled people in your research studies. It's worth it. It's worth the IRB hassle to justify our inclusion in research. But I also am going to challenge you to go beyond that and involve disabled people not only in as research subjects, but involve disability community in every phase of your research process. And this graphic depicts participatory action research. And in participatory action research, disabled people are involved in all phases of the research as, community consultants, as co-researchers, as participants. They're involved in everything. And in that way, the research has much more ecological validity and is able to be applied to the community and help the community that we're studying. This is a really cool chart out of the UK that is called IDEAS as the acronym, and it's basically the IDEAS checklist. When you're doing research that involves people with disabilities, inclusion, did we include people with disabilities and how? Dignity, how did we ensure that people were treated with dignity throughout this? Equity, how did we make sure that the policies and the inequities were addressed, right? So we want our research to make a difference. How is it making a difference? Was accessibility thought about? Did we think about how we're going to make things accessible? Like in this very presentation right now, they've thought about it. They've got captioning, they've got ASL interpreters. Those are the things that you want to think about and be prepared for. So it's the onus is not on the disabled person to say, hey, I need this accommodation. And finally, intersectionality. Just looking at disability is never enough. You really want to make sure that you're recruiting and being involved with a diverse range of people with disabilities, not just, white male men, not white men with spinal cord injury only, right? That you're really getting a good sense of our community and the diversity within it. So the last thing I want to talk about here is advocacy and how you can help. So we know that in March in the Northeast, or in March and April in the Northeast, where I guess y'all are, and then in the summer for us down here in Texas, we got to the point of overload with COVID, and the crisis standards of care were implemented. And during an emergency, things can change. And we saw that, right? Because HHS waived a whole bunch of federal regulations and made things possible for us as psychologists to practice that we couldn't before. But that never goes so far to allow discrimination. That's still not allowed. So what happens when the need arises and you've got to triage people? You don't have enough ventilators. You don't have enough ICU beds. Well, I'll tell you what we saw. We saw it immediately, the policies that came out, and they were based on quality of life judgments, and they were excluding patients with specific disabilities. It was pretty awful. It was basically, if someone has a severe disability, they are not to be prioritized for COVID care. It got so bad, at some point they were saying, if a patient comes into your hospital and they're on a ventilator, their own ventilator that they use every day, all day at home, you are to remove their ventilator and give it to another patient who could get more from it. This is illegal. And thank God for the disability rights lawyers. They got in there and they challenged it. And, a lot of these things have been overturned. But the problem is these decisions are not always being made in the public view. They're not always a policy that's out there for everybody to critique. It's happening like in the video I just showed you of Michael Hickson, single doctors or, small groups of people making decisions about people's lives based on their own biases. So it's really important to understand that this is illegal. And as psychologists, many of you work in hospitals, and probably some of you are, for example, on ethics committees. This is where you can really make a difference and work on making sure that your institution is not contributing to this problem. So there's specific things you want to look for. One is that these decisions are not being negatively affected by disability and also social circumstances, that they're not disproportionately affected people who are poor or people of color or people with disabilities. Not using long-term life expectancy. We should only be looking at near-term life expectancy, because we know that those predictions for long-term expectancy are very uncertain and very much prone to bias. And I can tell you a lot of people I know with muscular dystrophy were told that they were going to die by the time they were 10 and they're like 40 now. So it's not uncommon. So we can make triage decisions that are better supported. So never using categorical exclusions and never using perceived quality of life. It's way too subjective. We want to see hospital survival being used, near-term prognosis. Never, ever, ever threatening to take ventilators away from people with disabilities and their personal ventilators, because what happens is that person will not come to your hospital for COVID-19 because they're terrified you're going to take their vent. And I know it may be hard to believe that this was happening, but I assure you it was. Having triage officers making these decisions, take the onus off of these frontline physicians and these frontline providers, and make these assessments individually based on objective medical evidence. And in some instances, you can actually have the case presented with a lot of demographic information taken out so that they can't necessarily use that information in a biased way. And last but definitely not least, please include people with disabilities in the policy development and dissemination. It shows that you respect our community, that you're not trying to be paternalistic, and it's likely to actually improve the fairness and ultimately better triaging guidelines. So I want to thank you. I know I covered a huge amount of information, and we do have about 3 minutes, left for questions. Do we have any, Sarah?
Oh, thank you so much. That was fantastic. You did cover a lot of information, but very clearly and all incredibly important. I love the way that you covered every aspect of what people have to do in their work, including advocacy. So if people have questions, feel free to use the Q&A box or the chat box. I don't see any so far.
They're either asleep or their heads are spinning.
I just think it was honestly very clear. I have to say, I'm glad you're plugging your book. I just finished it, well, a couple months ago now. And it was just excellent. I learned so much. So I'll plug your book.
Thank you.
But I think it's important for people who are doing testing. It's important for people who are doing research. It's important for people who are doing treatment interventions from acute care through rehabilitation care. I just think she has a lot of really great information in there, very clearly put. Okay, so you have a comment.
All right.
This isn't a question, but I'm disabled. And if you have questions about an individual's accommodations, just ask. The most valuable resource for learning about disability is disabled people.
Amen to that.
And we do have one comment here. Thank you for an amazing and empowering presentation. Can you speak briefly about your book?
Yeah, I guess I'll just say a little bit more about the book. It starts with a lot of disability history. I think it's really important to know the foundation. I talk about disability culture, disability identity development, cultural competence. What does that mean? And encompassing cultural humility. There's a chapter on intervention. There's a chapter on assessment, and there's much more detailed than I was able to get today in both of those. And there's also a chapter, the last chapter is on research. So there's a lot more depth. You know, I just kind of covered the highlights. So I don't make very much money on this book, so I promise you I'm not like over here profiting too much. But it really is a labor of love. It took me over about 3 years to write, but I really am proud of it. And I think that what I really intended to do was give psychologists some good information and tools so that you're prepared. So like that last commenter said, like, get the information straight from the horse's mouth. Yes, do that, but also don't go into your therapy sessions putting the entire onus on the disabled person, like to tell you everything about everything. Like you also can do your homework and learn some stuff, but then honor their experience and find out what it's like for them. So I think you can do both. And I think by doing both, you're likely to be, optimally effective.
Great. You have a question about what was the Netflix movie? I think Crip Camp, is that the one that you mentioned?
Yes, it's called Crip Camp, CRIPCAMP, Crip Camp. It's really, really wonderful.
John, are there other messages in the chat?
No, I think that was everything. Dr. Marlowe just mentioned having attended a conference on crutches and feeling almost knocked down, and understands, we all just need to do a better job of being more aware of the experience of people with disabilities. So thank you.
All right. Well, again, thanks for having me. It's been a pleasure.
Thank you so much again. Really wonderful.
Bye-bye.
Bye.